A 9-year-old boy with a short stature has got a GI illness and now developed blindness. He has got elevated leukocyte count and elevated lactate also. And typically his MRI is showing the areas affected, and this is a classical case. In view of the elevated lactic acid, we call it as MELAS, which is mitochondrial encephalopathy with lactic acidosis and stroke-like episodes. 6-year-old boy has high arches and hamartos, and his nerve conduction and electron myography are abnormal, and sural nerve biopsy has been done. So this is a classical case of Charcot-Marie-Tooth syndrome, and typically in Charcot-Marie-Tooth syndrome, the patient will have a decreased conduction velocity and the nerve being abnormal due to the deposition. Now 56-year-old, 2 weeks of progressive headache, MRI is being shown. So what is it most likely to be? So basically among the gliomas and astrocytomas are same. You have the burst kind of glioma, which is called glioblastoma multiforme. So this kind of a large lesion which has got a cavitating interior and which is hyperintense on contrast is highly suggestive of glioblastoma multiforme. And for that the treatment would be to do the resection. Surgery is the only way. Not no. Stereotactic is for a small lesion. You don't want to disturb any area. This is like a big mass. It's a mountain sitting in the brain. It doesn't much help. But prognosis also very poor with glioblastoma multiforme. Now this is a neurodegenerative condition, and typically you have the Huntington's disease, typically presenting with dementia. What is this appearance of the ventricle called as boxcar like ventricles? Whenever the caudate nucleus happens to atrophy, then there is a dilatation of the ventricle, and the dilated ventricle typically, because this is the area where you find the caudate, once it degenerated you get a boxcar like appearance. A 11-year-old boy with respiratory distress with respiratory syncytial virus, and he has ketoacidosis, elevated ammonia and hypoglycemia, and urine organic acids are elevated, especially glutaric acid, and MRI is typically showing lesions, which is fundamentally the gluteryl-CoA dehydrogenase deficiency, which is better treated by supplementation with lysine and tryptophan. Once more, glutaric acid, lysine and tryptophan metabolism in biochemistry. Then you will understand how the gluteryl, where is the gluteryl dehydrogenase is involved. A 2-year-old is having generalized convulsions, developmental delay, microcephaly, appendicular hypertonia, cleft lip and axial and appendicular, axial hypotonia with appendicular hypertonia, and typically the MRI has been shown. So actually infantile spasms, generalized convulsions, mental retardation, chorioretinal lacunae, and the MRI showing agenesis of corpus callosum. That is what you need to appreciate in this. The corpus, normally here a strip will be seen, right, in the lateral view. So this strip of corpus callosum is missing, and that puts it as Aicardi syndrome. But don't worry, rare syndromes are unlikely in NEET PG. Even if they are given, rarely people will answer it. And correct. Okay, in view of the 2-year-old girl, obviously somebody should be boy or a girl, right? Either a boy or a girl it should be. But you need to give importance to all other things like upper limb hypotonia, lower limb hypotonia. But it's a good guess, Actual preparation of exam is not to be knowledgeable on everything. Its ability to use 30% of your knowledge to eliminate 70% of this thing. And unfortunately students study 70%, but they don't know how to eliminate and apply with some logic, some fuzzy logic. It can be right, it can be wrong. You have to apply. If you are logically applying mind, most of the toppers in entrance are all those who know how to apply logically, but read common things which are very interesting facts. And some numericals, etc., you must know that's inevitable part of our exam system. So what is the most common cause? What you are finding is a lobar hemorrhage. Lobar hemorrhage commonly is precipitated by hypertension. 23-year-old with a history of kidney disease, acute onset of headache, which is called thunderclap headache, and she is rushed to the hospital with ambulance and CT is being shown. What you are seeing is these are called Sylvian fissures. If you are able to see a bleed in the Sylvian fissure, not anywhere intracerebrally, only in the fissure you find the bleed, then that is subarachnoid. Why? Can you give me the board? So you have the brain, abutting the brain, you are having the pia mater. It almost sticks with the brain. Yeah, sticks with the brain. Above that you have the arachnoid. Above that you are having the dura. Above that you are having the skull. Between skull and the dura you call it as epidural. Between the dura and arachnoid you call subdural, which is a venous bleed. So, epidural is arterial bleed, and this lead to lucid interval, arterial. It is because of the rupture of the middle meningeal artery. You get it. Typically on a road traffic accident, somebody fell down and he has got a lucid interval, then he collapsed, is epidural. Elderly man, his brain is shrunken and the bridging veins got broken, and that led to a big patch of bleed which is semilunar in shape, is subdural, and they present with dementia, because that will have an effect on the brain long term. Then the next is after the dura and pia and arachnoid, between arachnoid and the abutting pia, you get a bleed which is called subarachnoid hemorrhage. So what is this bleed? How does this bleed collect? It is not into the brain, it is not into epidural, it is not subdural, but that will seep between the fissures, gyra and sulci. That is the reason whenever you take the CT, you find the Sylvian fissure filled with blood. So how is the Sylvian fissure is there? If the brain is like this, it will be passing like this. Into that, when the blood got collected, in this section it looks like two opacities. That's the point you need to appreciate. Now, so the question was vasospasm. Let us talk about that story also. There is something you should know about the vasospasm. Suppose if there is any bleed inside the brain, like intracerebral bleed, it lead to ischemic injury, and that should lead to contralateral hemiplegia, focal neurological deficits, etc. But subarachnoid hemorrhage is above the brain. It has no business of causing hypoxic injury and hemiplegia like focal neurological deficits. But if this bleed remains, you didn't properly hydrate the patient and you did not properly give the vasodilators, what will happen is the surrounding vessels like cerebral arteries are there, no? they are being surrounded by this blood in subarachnoid space, they lead to vasospasm, and that lead to hypoxia, and that lead to focal neurological deficit. So, what are the two important strategies whenever you are managing a case of subarachnoid hemorrhage? Number one, hydrate the patient. Give lots and lots and lots of water to hydrate him so that vasospasm doesn't occur. Calcium channel blockers, nimodipine you give to prevent vasospasm. Then you hyperventilate the patient and bring down the carbon dioxide intracerebrally. When you hyperventilate and bring down the carbon dioxide in the brain can lead to vasoconstriction. So you can prevent the development of vasoconstriction. So these are the essential things, and none of your subarachnoid hemorrhage patients should ever go into the state of vasospasm. That's what you need to remember. And that complication of vasospasm is typically during the first week. Time? When is her peak risk of developing vasospasm? It is 1 week. Now that is a fact on multiple studies, that 1 week, if you look at the chance of developing focal neurological deficit, most of the studies have shown first week is the time where if you don't properly hydrate them, properly give vasodilatation, they are at the risk of developing severe vasospasm. Peak value. No, this 1 week is the maximum risk is a very well known factual value. A 34-year-old excruciating headache after delivering her first baby, mild postpartum vaginal hemorrhage, and she reports inability to breastfeed, and the brain imaging has been shown to you. So, typically there is a hyperintensity in the pituitary area. So, this area, this is the hyperintensity in pituitary area. So, the hyperintensity in pituitary area means postpartum necrosis, Sheehan's, is what you need to expect. Now, what is the type of abnormality in the brain that you are looking? It is an example of the yellow bar holoprosencephaly. Now, with regard to the condition which is being shown to you, so what do you see? There is a big vein of Galen which lead to congestive heart failure. So, the fact is, it is not the low output cardiac failure, high output cardiac failure. Whenever the blood get accumulated within that big vein of Galen, then the heart has to struggle to pump because cardiac output get affected, it will go into high output cardiac failure. So, strokes can occur, and that can lead to development of the progressive heavy paresis. Is it not? No, Arnold-Chiari malformation for you to recognize. No, the cerebellar herniation. Herniation should happen. Here it is not showing any herniation of the cerebellum into the. This is the big venous. Here also you are seeing. Whereas there you have got a different appearance, Arnold-Chiari. Now, in this 45-year-old, what is the exposure this patient is having? So, typically, any prolonged carbon monoxide exposure is known to lead to development of a putaminal hemorrhage and bleed, is a well-known fact. Now, this is called as pie in eye appearance of the visual field defect. So, which is typically seen whenever there is any contralateral temporal lobe lesion. One of the visual field defects, every NEET PG exam they will definitely ask, so you should master it. 45-year-old, 2-year history of progressive weakness, severe dry mouth, and on nerve conduction sensory response is normal, but all motor responses have low amplitude, and repetitive stimulation is showing decremental and incremental. In myasthenia gravis you have decremental conduction, but here there is an incremental conduction. So that puts it in favor of Lambert-Eaton syndrome is what you need to basically remember. So it is due to the presynaptic voltage gated calcium channel antibodies which are responsible. 66-year-old dementia with a large intracranial hemorrhage, autopsy is being done, and what is this consistent of? So typically it is a amyloid deposition. So whenever typically one more thing should be added, that she doesn't have hypertension. Generally hypertension with stroke is known. Non-hypertensive, non-diabetic develops a stroke, you should highly suspect cerebral amyloid angiopathy, especially so when they have dementia. That is what you need to understand. Now the photomicrograph is typically there is a CADSIL gene which is affected. CADSIL gene is autosomal dominant form of inheritance. Now this photomicrograph is biopsied from the thigh muscle. So typically what does it show? It is showing a variation in the fiber size, central nuclei, increased endomyosial fibrous tissue and fat, which are all the classical features which are typically seen in Duchenne's muscular dystrophy. After a severe motor vehicle accident, a 50-year-old man comes to emergency, unconscious and intubated, and a CT scan of his brain is being shown to you. And after the assurance of a proper respiratory and circulatory support, as well as spinous imaging, so what is your conclusion? So there is a sulcal effacement and temporal horn enlargement, right? Temporal horn enlargement in the lateral ventricles. Intracranial pressure monitoring is all that is required in this given individual. A 23-year-old presents to the emergency with leg weakness, fall and numbness. He has been unable to control the bladder, and several episodes of incontinence is there, and she has a sensation of loss of vibration, pinprick in the hands, and the MRI is typically showing the presence of a huge lesion in the spinal cord. So typically she has got a transverse myelitis. Whenever there is any inflammation of the spinal cord, you can see the typical inflammation. And how do you identify transverse myelitis? Once there is a definite dermatomal sensory level, typically you will get a sensory level, below which there is sensory loss, above that there is sensation, but a definite cut is there, that is transverse myelitis. So basically what are the three important differential diagnoses of acute flaccid paralysis? Guillain-Barré syndrome, acute poliomyelitis or transverse myelitis. Poliomyelitis, it is pure motor paralysis. So Guillain-Barré, you have got the features of Guillain-Barré, you know, symmetrical ascending flaccid paralysis, symmetrical. Then transverse myelitis is definitely sensory loss. Brown sequid is very far off thing. Commonly these three are differential diagnosis because all the three will have fever followed by AFP. Whether you take poliomyelitis or transverse myelitis or Guillain-Barré. And the treatment is altogether different between the three. In case of the Guillain-Barré, if you happen to do the plasmapheresis etc., you will rescue the patient. Or IV immunoglobulin if you give. Whereas in the case of the transverse myelitis, steroid is the main part of the treatment. So diagnosis is all important. So this is typically a condition which is due to aquaporin 4. Antibodies can lead to this kind of a longitudinal severe transverse myelitis, longitudinally extensive in its appearance. It's called LETM. Very rare question. Not at MD level, it is at DM level. 8-year-old comes to office with evaluation of seizures, and he has reached all developmental milestones. In the last 2 years, he has a severe nocturnal episodes of twitching on one side of the face. EEG is being shown to you. So, typically this patient is having a benign epilepsy with centrotemporal spikes, they are called as, which is called Rolandic epilepsy. Classical centrotemporal spikes, which are classical of Rolandic epilepsy. Now, what is this most likely related? What is this abnormality? So, classically this is showing subependymal hematomatous lesions, which is classically a feature of tuberous sclerosis. You can see typically in this area subependymal hematomatous lesion. This is the lateral ventricles, and this is the area where you find the lesion, subependymal, which is seen in tuberous sclerosis. In tuberous sclerosis, a hematoma is fundamentally a cell growth pathway abnormality. It is not a tumor, but a misnomer called as hematoma. Now, this woman typically has got a problem in her conjugate gauge. Whenever she is looking that side, she is able to. But whenever she is looking this eye is unable to move. So, what is it? Basically, it's a left abducens palsy where the left eye is unable to abduct. Simple question. More challenging is medial longitudinal fasciculus and internuclear ophthalmoplegia. How to recognize it is very important. Right? Now, 16-year-old, typically periodic acid shift stain muscle biopsy is being shown. And what is the most likely diagnosis of this typical condition? So, it is a McArdle disease where called type 5 glycogenolysis, and that is the reason PAS stain is being used. Periodic acid shift stain will typically give the staining pattern if it is a glycogen deposition. 42-year-old with right wrist drop, with left foot drop, and he went a right sural nerve biopsy, which is showing a lot of inflammatory cells. So, it is typically a case of mononeuritis multiplex. Mononeuritis multiplex, which can be how do you recognize mononeuritis multiplex? Patient will have one hand radial nerve, another hand ulnar nerve, another leg sural nerve. You can't explain with any organic lesions in these multiple locations. Unless there is an antibody which is going and destroying the nerves in multiple locations systemically, you can't get mononeuritis multiplex. So, typically that happens whenever there is any vasculitis, autoantibodies to our own vessels leading to vessel inflammation to ischemia leading to injury. So, vasculitis can only explain the mononeuritis multiplex is what you need to basically remember, and that can be found in the case of ANK positive conditions like vagina, etc., etc. 43-year-old received surgery and high dose focal radiation. She now presents with neurocognitive deficits, and her MRI of the brain with the contrast has been shown. So, what is the typical condition that she is passing through? So, she has a history of radiation. So, it's a radiation necrosis, and it is symptomatic. It should be first treated with steroids and then anti-angiogenic treatment like the bevacizumab is the one which is basically used. 65-year-old man with long smoking history presents with a sudden profound painless monocular vision loss, and the fundoscopy has been performed, and typically what do you see? Here you are seeing typically a cherry red spot, which is often seen in central retinal artery occlusion is what you need to conclude. 67-year-old with dementia, autopsy is being performed, Then what is this? These are classical Lewy body, Lewy antibody dementia. Lewy body dementia is what you typically come across. Now in this condition in MRI, what is being shown? It shows schizencephaly, which is a development abnormality where the cleft extends from the ependyma to the pia mater lined by grey matter. From the ependyma to the pia mater lined by grey matter. So that is what you can be able to see. 26-year-old with headache and left arm numbness. She has got a spontaneous abortion 3 months ago. MRI of her brain has been performed. So what are you basically seeing? There is a contrast enhancing lesion on the MRI which you are able to see. And how do you describe this lesion? Typically it is located in the grey white matter junction. And this lesion is small, round and associated with significant surrounding edema. So all these features are in favor that this is a metastatic lesion. But what is the age group? She is a young lady. So young lady, what tumors can occur that can lead to metastasis with this kind of history? Choriocarcinoma can lead to vascular metastasis going to the brain, and they can present typically like this. History of abortion is there, yes. That suggests of a molar pregnancy, choriocarcinoma. So they are all the ones which are suggested by that. 56-year-old with acute hearing loss in both the ears, progressive confusion and visual field cut in the right eye, and MRI has been shown. So you should always remember one important point here, that actually this is a Suzuki syndrome, but that's unlikely to come in tomorrow's exam. So you can forget about that question as well. 73-year-old with headache and confusion 3 days after a fall. So I told you, whenever elderly man with a shrunken brain falls down and this kind of a semilunar bleed is there, that is subdural venous bleed that can present with dementia, is what you need to remember. So it is due to the result of tearing of the bridging veins. Diploic veins. Yeah.